Welcome to the Deep Dive. You're here, right? Curious, wanting to understand something a little better, maybe a little faster.
Yeah, and today, that something is, well, it's the fascinating and, let's be honest, often misunderstood world of the vulva and the vagina.
Exactly. We dove into a really great resource for this one.
We did. The Vagina Bible by Dr. Gunter. She's a practicing OBGYN, and the book is just, it's so comprehensive, science-based, really cuts through the noise,
It really does. So, okay, our goal today, pretty straightforward. We want to pull out the key insights, dismantle some of those myths that just stick around.
And give you a clearer picture, make it engaging, not overwhelming.
Right. So let's get into it, starting with something fundamental, actually.
Yeah, the basics, vulva versus vagina, a key point Dr. Gunter makes right off the bat.
So what is the difference, just to be clear?
Well, think of the vulva as everything external, what you can see, basically, where your underwear sits.
Okay.
The vagina is the internal canal, and that little area where they meet, the transition zone, that's the vestibule.
Got it. Vulva outside, vagina inside, vestibule in between. Simple enough.
Seems simple, yeah. But here's where things get, well, interesting historically.
Ah, you mean the whole dirty vagina myth?
Exactly. The book really digs into this. It's kind of wild looking back. In the 1920s, 1930s, a lot of doctors actually believed the vagina was, like, teeming with dangerous bacteria.
Seriously, that sounds counterintuitive.
Totally. Dr. Gunter points out, from an evolutionary standpoint, it makes zero sense. If that were true, how would the human race have even survived?
Right. So what was really behind it then? It wasn't actual hygiene concerns.
Not really, no. She connects it directly to broader societal things. Specifically, the historical oppression of women.
So portraying that part of the body negatively.
Fit neatly into a patriarchal view. Made it seem like something inherently flawed or unclean.
Wow. Okay, moving on from myths, let's talk anatomy again. Specifically the clitoris. It sounds like there's way more to it than usually acknowledged.
Oh, absolutely. And Dr. Gunter highlights how medicine, being so male-dominated for so long,
led to a very penis-focused view.
Precisely. A very penis-centric perspective on sex, and just a massive lack of research on the clitoris itself. And Freud's ideas didn't exactly help shift focus either. He kind of downplayed its importance in adult female sexuality.
A key piece was just ignored.
Pretty much.
Oh.
And then there's the anatomy itself. Most of the clitoris is internal, which, made it way harder to study compared to the penis.
Right, you couldn't just easily see it all.
Exactly. So even when they did cadaver studies later on, Dr. Gunter notes the limitations. Small sample sizes, often older people whose bodies might have changed.
And the preservation process could mess things up.
Yeah, distort the tissues. So MRI technology was a real breakthrough. Finally, we could see the living clitoris, how it actually works, how it responds.
Okay, so it's not just that, small visible part. What's the bigger picture?
It's so much bigger. A lot of experts now use this term. It's a bit of a mouthful, the clitorithrovaginal complex. But it highlights how closely linked it is to the urethra and the lower vagina. And here's the really key thing. All parts of the clitoris, not just the glands, the big you see, are involved in sensation. And all of it is erectile tissue.
Wait, all of it? Even the internal parts?
Yep. The glands actually has the most nerve endings, but the least erectile tissue. Right. It's the body and the crura, those internal legs that run along the pubic bones, that have the most erectile tissue.
Huh. That's fascinating.
And it explains a lot. Like Dr. Gunter points out, this is why women born without a glans, or who've had urethral surgery, or even women who've undergone FGM, they can often still experience orgasm.
Because the sensation comes from the whole complex.
Exactly. The whole area is capable of sensation, which really opens things up for what she calls sexploration.
Exploration. I like that. Okay, shifting from pleasure to, well, something often linked to first experiences, the hymen. What's the real story there? Any evolutionary purpose?
Dr. Gunter really takes apart those evolutionary theories. The one about it making first intercourse painful to, encourage bonding with one partner.
Yeah, I've heard that one.
Well, she points out, just look at teen pregnancy rates. If it was consistently that painful, those rates probably wouldn't be what they are. It just doesn't quite add up.
That's a very practical point. So it's not about pain, and it's definitely not some kind of virginity indicator.
Definitely not.
Yeah.
That's another myth she tackles head on. She explains it's simply a remnant from when the vagina develops in the fetus. It starts as a solid tube, and the cells in the middle dissolve away. The hymen is just whatever tissue is left at the bottom end.
So it can look different in everyone.
Exactly. It can be a ring, a crescent, have different size holes, or sometimes it's just not there at all from birth. Occasionally, you might get thicker bands called septa, and those can stretch or tear with things like tampon use or penetration.
But not some designed-to-break seal. Okay, got it. Let's talk size. Is there a standard or normal vaginal length?
Not really a standard, no. Dr. Gunter highlights there's actually a pretty significant range. The back wall could be anywhere from, say, 5 to 14 centimeters. The front wall may be 4 to 8 centimeters.
Wow, that's quite a difference.
It is. And here's a really important point she makes. Your overall body size doesn't predict your vaginal length at all.
Good to know.
And remember, it's not just a straight tube either. It tends to widen out closer to the cervix.
Right. Okay, what about the muscles down there? The pelvic floor muscles. We hear about Kegels, but what do they actually do?
They do a lot. They're absolutely crucial. Think of them like a sling or sort of a hammock made of 2 layers of muscle at the base of your pelvis.
Supporting everything.
Exactly. They support your pelvic organs, bladder, uterus, rectum. They're key for continence, controlling your bladder and bowels. And they contract during orgasm.
How many times?
On average, somewhere between 3 and 15 rhythmic contractions. Plus, they even contribute to your core stability and posture.
Wow, they are multitaskers. Okay, let's tackle something that causes a lot of uncertainty. Vaginal discharge. Is it always a problem?
No, definitely not. And this is a really important thing to clear up. Dr. Gunter points out there's this growing idea, often wrong, that any discharge means something's wrong.
Why do you think that is?
She suggests a few things. Maybe the very dry look often seen in mainstream porn, or just a general lack of open talk about vaginal health. Maybe pubic hair removal makes it more visible.
Or all those feminine freshness products being marketed.
That too, definitely. Yeah. It creates this pressure. But Dr. Gunter reminds us, a healthy vagina has this whole community of good bacteria, mostly lactobacilli. Actually, thanks to DNA tech, we now think Ehlers is probably the most common type, which is a shift in understanding.
So the discharge itself isn't the enemy?
Not at all. It's a sign of a healthy, functioning system.
Of course.
If you notice big changes, color, smell, consistency, especially with itching, burning, or pain, then yeah, definitely get it checked out.
That makes sense. Check for changes or other symptoms. Now, the book also covers transgender health, which is so important. What are key things to know about vulvar and vaginal health for trans men and women?
Yeah, this is a really vital area. For trans men taking testosterone, they often see changes like clitoral enlargement, maybe increased sensitivity, different pubic hair patterns.
Okay.
But critically, they also face a higher risk of abnormal pap smear results. And getting adequate cervical cancer screening can sometimes be challenging, maybe due to inflammation or discomfort. There was also some suggestion of a possible increased risk for HPV.
That screening point is crucial if they still have a cervix. What about trans women?
So trans women might have vaginoplasty, that's surgery to create external genitalia labia, a clitoris, often using tissue from the glans penis, and a vaginal canal.
And sexual function after that.
Well, the new clitoris and also stimulating the prostate gland can contribute to pleasure. And reported rates of sexual activity and orgasm after surgery are generally pretty encouraging.
That's good to hear. Any potential complications?
Sometimes pain during intercourse can happen. It might be due to stenosis, that's a narrowing of the neovagina, or pelvic floor muscle spasms. Often, using dilators regularly is needed to maintain the vaginal depth and width.
And STI risks after vaginoplasty.
It's a bit complex. If penile tissue is used, it might not be susceptible to things like gonorrhea or chlamydia in the same way, but the urethra is still there, so that can get infected. Viral STIs like herpes and HPV. Transmission is likely possible, but it's an area that really needs more research.
So, bottom line for trans health here.
For trans men with a cervix, the risks around pap smears and screening access are key. For both trans men and women, things like discharge or pain can come up. Trans women might deal with pain from stenosis or muscle issues. Dr. Gunter really stresses HPV vaccination and making sure trans folks have access to appropriate cancer screenings.
Got it. Okay, stepping back a bit. Overall sexual satisfaction, the book mentions surveys.
Yeah, it's interesting. The data suggests that across different orientations, only about 47 to 51% of women report being satisfied with their sex lives.
Huh. Not as high as you might think.
Right. And actually, reported satisfaction for straight men isn't massively higher, around 51%. It just shows that satisfaction is, well, complicated. It's not just about the physical act.
Absolutely. And speaking of complicated, let's dive into the whole vaginal orgasm myth and the G-spot.
Yes, the elusive G-spot. Dr. Gunter is very clear. If you don't orgasm from penile penetration alone, that is totally normal. It's a feature, not a flaw, she says.
I like that framing. So the G-spot isn't a real thing.
Well, the idea of this single magic button, no. It seems Dr. Grafenberg, back in the 50s, described an erotic zone near the urethra. Modern science suggests he was likely talking about the internal parts of the clitoris, the body, the roots, the bulbs which surround the urethra.
So stimulating that area is really stimulating the internal clitoris.
Pretty much, yeah. Research hasn't found any distinct separate G-spot structure. It's the urethra, the clitoris, the vaginal wall, all interacting. Stimulating that zone can feel good for many people because it hits the clitoris indirectly. But it needs the right kind of pressure, the right rhythm. It's definitely not just an on-off switch.
Which might explain why some women feel pressure to fake orgasms because of this expectation.
Exactly. There's been this cultural idea that orgasm should happen that way.
So how do orgasms work physiologically? What does the latest science show?
Well, MRI and ultrasound studies are pretty cool here. They show that no matter the stimulation, penile compression, external touch, internal penetration, the response leading to orgasm involves the clitoral tissues becoming engorged with blood.
It all comes back to the clitoris.
Pretty much. And interestingly, even stimulating the nipples can activate the same brain areas as clitoral stimulation. It really reinforces the clitoris as the central organ for female sexual pleasure.
The unsung hero indeed. Okay, another fascinating topic. Female ejaculation or squirting. What's the science on that?
Right. Dr. Gunter discusses a study where they actually collected and analyzed the fluid that women reported squirting during orgasm.
What was it?
The analysis was clear. It was urine. They observed the women's bladders filled up quickly during arousal and were empty right after the squirting happened.
So it's not some unique fluke.
The current scientific thinking is that it's likely one of two things. Either a really strong orgasm causes pelvic floor muscles to contract intensely and release urine, or maybe intense arousal just makes the bladder fill faster, leading to release.
Interesting. Okay, let's touch on anal sex. It can be a sensitive topic. What are the key points from the book?
Several really important ones. First, she talks about coercion and situations where anal penetration is framed as accidental when it was planned without consent. She stresses that should never be trivialized.
Absolutely.
Second, she pushes back hard against the myth that it's somehow better for men due to tightness, countering that whole damaging loose vagina idea. Her advice is really direct. Women should only engage in anal sex if they are genuinely interested and give enthusiastic consent.
And safety.
Crucial. Condoms are vital for preventing STIs, including HPV, which can cause anal cancer. And remember, there's no routine anal cancer screening for women, so prevention is key.
Good point. What about exploring it safely?
For anyone interested in exploring anal stimulation on their own terms, she suggests using anal toys specifically designed with a flared base that prevents them from getting lost inside, allowing for safer exploration and control.
Okay, good practical advice. Let's shift now to pregnancy and childbirth. Huge changes happen then. What about vulvar and vaginal health during pregnancy itself?
Yeah, early pregnancy brings a lot of hormonal shifts and increased blood flow. This can make the vulva and vagina feel more engorged, sometimes even look a bit bluish. That's called Chadwick's sign. Tissues get softer too. And something called cervical ectropion can happen, leading to more discharge and maybe even some light spotting or bleeding. But Dr. Gunter is really firm. Any bleeding during pregnancy needs medical attention. Never just assume it's okay.
Right. Don't ignore bleeding. What about sex during pregnancy? Generally okay.
Generally, yes, it's considered safe unless there are specific high-risk issues, like if your water has broken or you have placenta previa or a high risk of preterm labor. Your doctor would advise you on that.
Okay.
She does mention a very, very rare risk, a fatal air embolism, if air gets forced into the bloodstream via the placenta during oral or vaginal sex. Extremely rare, but worth knowing it's a theoretical possibility.
Wow, okay. And after the birth, the postpartum period, what happens then?
It's a time of major healing. You can expect swelling, bruising, maybe tears in the perineum needing stitches, hemorrhoids, all contributing to pain and discomfort.
And recovery takes time.
Definitely. Longer labors, fatigue, forceps, or vacuum use can make it tougher. If there are severe tears, 3rd or 4th degree, 5V antibiotics might be given to prevent infection. Common issues in the first weeks are ongoing hemorrhoids, maybe constipation, discharge as things heal. It's really key to watch for signs of infection, worsening pain, redness, pus, fever.
What about that husband stitch myth? Does she address it?
She does. She acknowledges hearing about it, the idea of an extra stitch for tightening. But she says in her extensive practice, she's never seen a verifiable case. persistent tightness or pain after birth. Much more likely due to pelvic floor muscle spasm, not some deliberate extra stitch.
That's helpful to clarify. And the book mentions that libido changes aren't just physical, right? Even adoptive parents experience shifts.
Exactly. She points out that similar changes in libido and sexual satisfaction happen in gay male adoptive parents too. It suggests the huge impact of parenthood itself, the stress, the focus shift, plays a big role beyond just the biological changes of pregnancy and birth.
So summing up pregnancy and childbirth impacts.
Okay, perineal tears are common. Resuming sex, usually around 6 weeks postpartum, but breastfeeding can sometimes make it painful initially.
Right.
Pelvic floor physical therapy is highly recommended for incontinence. Kegels help too. And while delivery method might affect things short-term, it usually doesn't cause long-lasting sexual function issues for most.
Okay, let's clarify something important. Screening tests versus diagnostic tests. What's the difference?
Good distinction. Screening tests are for large groups, often people without symptoms, to catch potential issues early. Think routine pap smears for cervical cancer or STI testing for young adults.
Right.
Diagnostic tests are used when someone has symptoms, or if a screening test is abnormal. They're meant to figure out the cause. So swabbing a sore to test for herpes or a biopsy of an unusual skin patch. And Dr. Gunter adds, diagnostic tests can also rule out conditions, which is important too.
Helpful. Okay, very briefly, the menstrual cycle. What's the basic driver?
In essence, it's a really complex hormonal dance, regulated by the hypothalamus and pituitary gland in the brain and the ovaries. Dr. Gunter uses a nice analogy like 3 jugglers keeping multiple hormone balls in the air constantly.
Nice visual. Now, pelvic exams, often not looked forward to. What should we know?
Well, first, for chlamydia screening in sexually active folks 24 and under, annual screening is recommended, and urine tests are effective and often preferred.
Good to know. And the exam itself?
Usually 2 parts. The speculum exam lets the provider see the vagina and cervix. Then the bimanual exam, using fingers internally and a hand on the abdomen, assesses the uterus, ovaries, pelvic floor muscles. Sometimes a rectal exam is needed too.
It's also important to remember the history here, isn't it?
Absolutely. Dr. Gunter doesn't avoid the difficult history, including J. Marion Sims's unethical experiments on enslaved black women. It's a crucial dark part of gynecological history to acknowledge.
And if an exam is painful, what should happen?
Dr. Gunter is adamant it should stop, unless it's a literal life-or-death emergency, which is incredibly rare in this context. Pain means stop, adjust the technique. A compassionate provider is key. It should not be forced.
Okay, let's talk food. Does what we eat affect vaginal health? Are there good or bad foods?
Short answer, no. Dr. Gunter really debunks this idea. There's no magic anti-Candida diet for yeast infections. And unless your diabetes is really uncontrolled, affecting urine sugar, diet doesn't cause yeast infections.
What about cranberry juice for UTIs?
No good evidence it prevents them. Fiber is good for overall gut health, which helps indirectly. Fermented foods might help gut bacteria during antibiotics. But evidence is shaky, and, crucially, food cannot change your vaginal scent.
Okay, so no special vaginal diet needed. What about underwear? Cotton only? White only?
Another common recommendation she challenges, the vulva and vagina are pretty resilient, actually. For underwear to cause problems, it would have to drastically change the environment. pH, moisture, friction.
And studies don't show that happening.
Right. Studies haven't found tight clothes affect vulvar bacteria or pH. Performance undies, thongs, no proven negative impact. Vaginal pH is an inside job, basically, maintained by the body.
Good news for my non-cotton collection. Okay, lubricants. What's important when choosing one?
Well, personal preference is huge, right? Slip, tackiness, cleanup, taste.
Sure.
But beyond that, crucially, you want one that won't irritate tissues or harm the good vaginal bacteria. The WHO World Health Organization actually has guidelines.
Oh, what do they recommend?
For water-based lubes, pH between 3.5 and 4.5, and osmolality, basically concentration under 380 mg/kg. This minimizes irritation and harm to lactobacilli.
Are there ingredients to avoid?
Yes, she lists a couple. Chlorhexidine gluconate and polyquaternium. Also, be wary of those warming, cooling, or tingling lubes, often irritating. And don't assume natural automatically means safe.
Good tips. Let's revisit pelvic floor exercises, or Kegels. Are they as simple as they sound?
Not always. Dr. Gunter explains that while things like biofeedback can measure contractions, they aren't usually needed initially. A lot of women actually struggle to isolate the right muscles.
They tighten other things instead.
Yeah, abs, glutes, or they hold their breath. And things like childbirth tears or nerve damage can make it harder too. Also, there's no strong evidence that fancy devices or expensive trainers are better than just learning correctly at home with good instruction. Maybe some apps could help guide you.
So what are the proven benefits?
They definitely can help with incontinence, bladder, and bowel leakage. They can help manage prolapse symptoms, maybe improve orgasm strength, but for preventing problems in women without symptoms, not much good data. And yeah, they're biomechanically trickier than they seem.
Okay, let's talk washing. Vulvar cleansing. What's the best approach?
Dr. Gunter connects the whole idea of feminine cleanliness back to those historical patriarchal views, normal genitals and secretions being seen as dirty, and of course product marketing. Washing is actually most important if someone has incontinence to protect the skin barrier. Otherwise, focus externally. Groin, outer labia, majora, mons pubis, around the anus.
And inside the labia minora or vestibule?
Best to avoid washing in there with product. Plain water rinsing is fine. Frequency, it's individual based on odor, after sex, after periods, whatever feels right for you.
Soap or cleanser?
Cleansers are generally better. Soap can strip the skin's natural protective acid mantle and raise the pH, leading to irritation. And those specific feminine washes, generally unnecessary, often contain irritants and promote harmful messaging. Wipes too, unless needed for incontinence.
And wiping after the toilet?
Gently blot directly on the external anal sphincter. A bidet is a great gentle option if available.
So the theme is gentle, external, and avoid overdoing it. What about historical vaginal cleaning practices?
Yeah, there's a long history of using astringents or antiseptics internally, often tied to achieving dry sex for male pleasure, sometimes control, sometimes even misguided ideas about treating erectile dysfunction. Understanding that helps see why fear around normal discharge persists.
And modern intravaginal cleaning, like douching.
Dr. Gunter covers douching, internal wipes, washes, deodorant suppositories. She notes that studies show many women who douche plan to keep doing it, suggesting complex social or cultural reasons.
Even though there's no benefit and potential harm.
Right. While specific studies on internal wipes or sprays are lacking, they likely carry similar risks to douching irritation, allergies, disrupting good bacteria. And the marketing messages are often harmful, implying something is wrong with the normal state.
Less is more seems to be the mantra. Okay, pubic hair. Does it have a biological purpose?
Possibly a few. Maybe some role in sexual pleasure via nerve stimulation. Maybe helping disperse odors or trap pheromones. It's different from hair follicle spacing, growth limit. Doesn't change much with pregnancy, but does thin and gray with age like other body hair.
And removal is so common now. Any risks?
Extremely common, yeah, especially among younger women. But few discuss it with their doctors. Dr. Gunter advises caution with removal for people with diabetes or suppressed immune systems due to higher infection risk.
And STIs? Is there a link?
Some studies suggest a possible link. The idea is that microtrauma, tiny cuts or abrasions from removal, could make it easier for STIs to get in.
If someone chooses to remove hair, any tips for doing it more safely?
If shaving, soften hair first, use a sharp, fresh razor. Shave with the hair growth, don't pull skin taut, change razors often.
Yeah.
Electric razors might be less irritating for some.
What about chemical creams?
Depilatories. They work, but risk irritation or allergic reactions. Use cautiously on delicate skin, and any cuts or ungrown hairs can get infected. See a doctor for increasing redness, pus, significant pain, or weird acne-like bumps. Could be hidradenitis suppurativa.
Should we moisturize the vulva?
It can definitely help protect the skin barrier, reduce dryness, itching, small fissures. Especially useful if you remove hair, use soap, or just have naturally drier skin due to aging or medications.
When should you see a doctor about dryness?
If it persists after a week or two of using a gentle moisturizer, get it checked out. Preventative moisturizing. May be helpful for older folks, those who remove hair, have incontinence or skin conditions. Always check with a doctor if you have an existing condition, though.
What ingredients are safe?
Simple is often best. Petrolatum, mineral oil, liquid paraffin, coconut oil, olive oil. Avoid lightening creams, potential irritation, unknown long-term effects. Apply externally, labia majora, perineum, around the anus, not inside.
Okay, let's discuss menstrual toxic shock syndrome, MTSS. Sounds scary. What is it?
It is serious but rare now. Symptoms are sudden. High fever, sunburn-like rash, low blood pressure, vomiting, diarrhea. Can lead to organ issues or, very rarely now, amputation.
How common is it?
Much rarer than in the late 70s or early 80s. Now maybe 1 in 100,000 reproductive age women. Key risk factors involve having a specific toxin-producing Staph aureus bacteria, only about 1% carry it, introducing oxygen into the vagina using higher absorbency tampons than needed, and maybe some trauma from insertion removal.
What about menstrual cups?
They can also allow bacterial biofilms to form. Interestingly, thermoplastic elastomer cups might grow less biofilm than silicone ones.
So how to minimize risk? Practical tip.
Use the lowest absorbency tampon you need. Change frequently every 48 hours. Consider pads overnight. Wash hands before insertion. Insert carefully. There's no predictive test, sadly.
Key points.
Low risk for most. Oxygen seems key. Cups aren't automatically safer than tampons regarding TSS.
Yeah.
All cotton tampons aren't proven safer. Avoid sea sponges.
What about general toxins in tampons and pads? Lots of period panic online.
Yeah, Dr. Gunter addresses this. In the U.S., these are FDA regulated. Manufacturers have to show they're free of harmful pesticide herbicide levels. The dioxin concern, mostly historical from old bleaching methods. Trace amounts from environmental pollution and raw materials, cotton, wood pulp, exist, but aren't from the manufacturing itself now.
And cups as an alternative.
Good, reusable, eco-friendly option, silicone, latex, TPE. Just be careful with latex allergies. Reiterate, cups aren't proven safer. DSS. Having 2 cups helps with proper cleaning between uses. Disposable cups exist but aren't well studied, though similar to diaphragms.
Okay, let's talk menopause and GSM genitourinary syndrome of menopause, the name changed.
Yeah, from vaginal atrophy, which sounds pretty... No, GSM is broader, covering changes in the vulva, vagina, bladder, the urethra due to lower estrogen.
What kind of changes happen?
Tissues can become fragile, less elastic, skin thinner, drier, fat redistributes, labia might change shape, vestibule might stretch less easily, clitoral erectile tissue can decrease, though it's unclear if that directly causes sexual issues.
Does it affect everyone?
Many women don't seek help or aren't asked about it. About 50% show microscopic tissue changes, but that doesn't always equal pain with sex. Pain is complex.
Does staying sexually active help prevent the tissue changes?
Interestingly, a 2017 study found no difference in cellular changes between active and inactive menopausal women. So sex itself doesn't seem to protect the tissue at a microscopic level.
Can it get severe?
Rarely, severe inflammation can cause scarring. Regular stretching, dilators, or penis might help prevent that, but it's uncommon. Extreme GSM pain can trigger pelvic floor muscle spasm or vaginismus. Also, other estrogen-lowering meds can sometimes cause similar symptoms.
So bottom line on GSM?
Physical changes affect multiple areas. Affects about 50% of women. Dryness is most common symptom. Sexual difficulties reported by about 25%. Self-efficacy is important.
What are the treatments for GSM?
Vaginal moisturizers give temporary relief, lower pH slightly, but don't regrow good bacteria. They improve comfort, not necessarily tissue appearance microscopically.
Yeah.
Different bases exist. Water, silicone, oil, hyaluronic acid.
And hormonal options?
Vaginal estrogen, creams, tablets, rings, is very effective for the tissue changes and lubrication. Dosing varies, often start nightly, then reduce to twice weekly.
What about bioidentical hormones?
It's a marketing term, no medical meaning. Chemically identical hormones are the same, whatever the source.
What if someone has had breast cancer?
Try non-hormonal options first. Moisturizers, lubes. But low-dose vaginal estrogen, the ring, 10 milligram tablets, is generally considered safe for most, always discussed with their oncologist. No safety data on vaginal DHEA. Hormone monitoring isn't usually needed, but can be reassuring.
And cannabis lubes? Any science?
Not really. No studies support claims of enhanced sexual function. One study suggests natural endocannabinoids might decrease with arousal. No data on vaginal cannabinoid receptors. Be wary of claims.
How does contraception interact with vaginal health?
Condoms are the clear winner as a vagina defender, she says. Consistent use with male partners leads to healthier vaginal bacteria important with multiple partners, or if a partner has other partners. Healthy bacteria are the first defense against STIs.
Anything else? IUDs?
About 7% of IUD users might show actinomyces bacteria on a pap smear, likely from biofilms on the string. Usually an incidental finding, no treatment needed if asymptomatic.
Hormonal contraception and HIV risk. Any connection?
There were early theories and some suggestive data about impacts on lactobacilli, mucus, immunity, lubrication. But it's complex, could be correlation, not causation. Needs more research.
Antibiotics and probiotics. Do probiotics help vaginal health?
Huge market, limited quality research. For generally healthy people, no evidence supports routine probiotic use. For specific conditions like recurrent BV, yeast, UTIs. The idea sounds good, restore lactobacilli, but rigorous analysis shows no proven benefit yet. Data quality is low. Studies often didn't even check if vaginal lactobacilli increased.
What about cosmetic procedures like labiaplasty?
Yeah, labiaplasty is way more common now. Historically, for significant asymmetry, now often sought for labia within the normal range. And normal is a huge range, 210 centimeter length, 0.75 centimeter width for labia minora. Larger labia don't inherently cause issues. Chronic irritation or pulling can enlarge them. Labial elongation is even desired in some cultures, no negative effects.
What about vaginal rejuvenation with lasers or radiofrequency?
ACOG advises caution. These are understudied, not recommended outside research. Studies comparing them to estrogen often used ineffective estrogen doses, making comparisons difficult.
Moving on to STIs, what are the main risk factors?
Multiple partners, recent partner change, inconsistent barrier use, having bacterial vaginosis, BV, makes you more susceptible to gonorrhea, HIV, receptive anal sex, partnering with a bisexual man. Those last two carry higher specific risks.
Where can people get tested?
Provider's office, FTI clinics, health departments, even home testing kits now. Urine, blood, HIV. Home tests can catch missed infections and offer privacy. County STI clinics often have tons of experience. Laws for minors vary by state.
So the STI bottom line.
Anyone who's had sex is potentially at risk. Higher risk if younger, multiple new partners, no barriers. BV increases risk. Lots of testing options exist, including confidential ones.
What about prevention beyond just condoms and abstinence?
HPV vaccines are incredibly effective against cancers, cervical, vulvar, vaginal, anal, and warts. The myth about ineffectiveness for Black women is false. They're underutilized in the U.S. Very safe formaldehyde levels are minuscule compared to natural levels. Vaccination doesn't increase risky sex.
And condom effectiveness.
Pretty good. 90% for gonorrhea, chlamydia, likely similar for trichomoniasis, 85% for HIV, maybe 70-80% for herpes HPV, harder to study. Won't stop pubic lice. She lists some brands without detectable nitrosamines, reminds about correct male condom use, benefits of female condoms too.
You mentioned microtrauma earlier, facilitating HPV.
Yeah, tiny breaks in the skin make it easier for HPV to infect. This might be the link between pubic hair removal and increased HPV risk.
How does HPV cause cancer or warts?
High-risk types like 16-18 hijack cell DNA leading to cancer. Types 6 and 11 cause most warts similarly, but non-cancerously. Smoking makes HPV progressing to cervical cancer more likely. Cervical cancer is a global issue. Vulvar, vaginal, anal cancers are less common, but HPV-related anal cancer seems to be rising.
Treatments for warts.
Patient-applied creams, imicamod, cinecatechins, or provider treatments, cryotherapy freezing, acids like TCA, BCA, surgery. Side effects vary, some are safe in pregnancy.
Let's talk herpes simplex virus, HSV. Key points.
HSV-1, often oral, now causes about half of new genital herpes cases, partly due to less childhood exposure giving immunity. Having oral HSV-1 usually protects against genital HSV-1 later. Prior HSV-1 doesn't prevent HSV-2, but might make genital HSV-2 milder.
How common is it? Do people know they have it?
Globally, HSV-1 antibodies are very common. HSV-2 less so, but higher prevalence in women. In the U.S., ages 14-49, about 15.5% have HSV-2 antibodies. But most people with herpes, maybe 80%, don't know. Classic sores might be absent or mistaken for something else.
How is it tested?
Blood tests for IgE antibodies can be useful sometimes. Recurrent weird sores, partner has it, high-risk behavior. But IgM tests are unreliable. Usefulness depends on how you'll use the result. Best test during an outbreak is a viral culture from the sore itself.
Treatment. Cure.
Not curable, but antivirals are effective for treating outbreaks and reducing shedding, transmission risk. Can take them episodically during outbreaks or suppressively daily.
Risk to newborns.
Yes. Vertical transmission is a risk, often happens during asymptomatic shedding. Antivirals late in pregnancy and C-section, if lesions are present at delivery, help reduce risk.
Herpes bottom line.
Both HSV-1 and HSV-2 cause genital herpes. Many are unaware. Testing exists, but consider why you're testing. Antivirals help manage it.
Briefly, gonorrhea and chlamydia.
Mentioned as common bacterial STIs, often asymptomatic, treatable with antibiotics. Partner treatment is crucial.
And trichomoniasis.
Affects about 3% of U.S. women 14 to 49. Risk increases over 40. Big issue. 85% are asymptomatic, or symptoms take ages to appear. Relying on symptoms isn't enough.
Consequences.
Increases risk of getting other STIs like HIV and PID. Facilitates HIV transmission. Common symptoms if they occur. Discharge change, frothy yellow-green, odor, irritation, painful urination, sex, lower abdominal pain.
Testing.
Office tests, wet microscopy, pH test, whiff test, ohming test.
Yeah.
High pH plus fishy whiff suggests TRICH or BV. More sensitive tests exist. Anatides, rapid antigen.
Trichomoniasis bottom line.
Common, often asymptomatic, risk up over 40, increases other STI risks. Testing, often not standard, so ask for it. Mainly sexual transmission, rare non-sexual via wet contact possible.
What about pubic lice?
Parasites adapted for pubic hair. Incidence falling, likely due to hair removal.
Okay.
Main symptom, intense vulvar itch. Can take 4 weeks for symptoms to show.
Treatment.
OTC meds, permethrin, pyrethrin, piperonal butoxide. Avoid vestibule vaginas. Use knit comb. Usually need a second treatment a week later. Wash bedding towels clothes in hot water. Dry hot to prevent reinfection.
Pubic lice, bottom line.
Pubic hair parasites. Itch is key symptom. OTC treatments work but need to kill lice and nits. Wash everything.
Okay, let's tackle yeast infections again, specifically diagnosis and treatment. Sounds like they're often misdiagnosed.
Hugely. Overdiagnosed and underdiagnosed. Many women thinking they have chronic yeast actually have something else. Remember, yeast, candida, is normal flora. Colonization without symptoms is common. 20 to 65% maybe. Less common post-menopause without estrogen. Higher pH then might make infection harder anyway.
What triggers symptomatic infections?
Antibiotics, pregnancy, high estrogen birth control, uncontrolled diabetes, suppressed immunity, maybe tight non-breathable clothes, hygiene products, sex, lots of potential factors.
Self-treating is risky.
Very. Many women self-diagnosing are wrong. Repeated unnecessary treatment fuels resistance. Get diagnosed properly.
How are they diagnosed?
Microscopy in the office? Quick, cheap, but misses 30–50%. Culture is the gold standard, identifies the specific yeast type, important for resistant recurrent cases, takes days, costs more.
And probiotics for prevention.
Still no good evidence for it.
Yeast, bottom line.
Yeast is normal. Why it overgrows isn't fully clear. Most are C. albicans, but others are increasing. Oral topical antifungals are equally effective. If treatment fails, get a culture.
And bacterial vaginosis. BV, remind us what it is.
Bacterial imbalance. Fewer good lactobacilli, overgrowth of others like Gardnerella vaginalis. Symptoms vary. Increased discharge, fishy odor, especially after sex ejaculation mixes with BV compounds, irritation.
Causes. Links.
Primarily linked to sex. Lactobacilli might get disrupted after becoming sexually active. More male partners increases risk. Some men might carry biofilms on the penis. But treating male partners hasn't helped prevent recurrence.
Treatment. Recurrence.
Oral metronidazole or clindamycin or vaginal versions. For recurrence, intravaginal boric acid after oral antibiotics, but before vaginal metronidazole is sometimes recommended. Disrupts biofilm. Weekly boric acid or boric acid alone isn't recommended, though.
Other things to help recurrent BV.
Condoms with male partners, non-spermicidal. Don't share sex toys with female partners. Consider partner testing treatment. Estrogen-containing contraception, pill, ring, patch, maybe continuous use. Consider IUD role. Biofilms, spotting won't play a part.
BV, bottom line.
Common imbalance linked to sex. Not always symptomatic. Treatable with antibiotics. Recurrence is tough. Boric acid and other strategies might help.
Let's talk about vulvodynia, chronic vulvar pain. What is it exactly?
It's chronic vulvar pain, 3+ months, with no identifiable cause. Can be localized, like provoked vestibulodynia, pain on touch, or generalized. Many women suffer undiagnosed for years, often told it's chronic yeast, but vulvodynia usually lacks the intense itch. Accurate yeast diagnosis, culture, is crucial.
What causes it?
Unclear. Potential factors: nerve injury, irritation, inflammation, genetics, hormones, pelvic floor muscle issues, psychological factors, birth control pills, unlikely cause. Topical lidocaine numbing agents, pelvic floor physical therapy, nerve pain meds, PCAs, SNRIs, gabapentin, pregabalin, surgery for provokes vestibulodynia sometimes, restrictive diets like low oxalate, no evidence.
Does diagnosis require a speculum exam?
Not necessarily to diagnose or treat associated pelvic or muscle spasm, PFMS. If periods are regular, internal obstruction is unlikely. Botox for PFMS is sometimes used off-label. Things that don't work: routine lab imaging, acupuncture, biofeedback alone.
Vulvodynia, bottom line.
Chronic vulvar pain, no clear cause. Diagnosis often delayed. Many potential factors and treatments. Accurate diagnosis ruling out other things is key.
What about other vulvar skin conditions? Itch is common.
Yeah, and biopsies aren't always definitive. Pathologists see patterns. Multiple conditions can coexist. Common itch causes: irritants, eczema dermatitis, lichen simplex chronicus, that itch scratch cycle.
Treatment for general itch.
Avoid irritants. Topical corticosteroids. Strength duration varies. Calcineurin inhibitors. Oral nerve pain meds sometimes.
What about specific conditions like lichen sclerosis or lichen planus?
These are autoimmune, affect 1–3% of women. Lichen sclerosis equals vulva only. Lichen planus vulva, vagina, mouth possibly. Cause itch, pain, pain with sex, ulcers, fissures, skin changes, whitening, thinning, scarring. Increased risk of vulvar squamous cell cancer, 6% over 10 years, so need close monitoring. Treatment: high-potency topical steroids, surgery for scarring but not lost labia minora,
Other conditions.
mollustum contagiosum, viral pearly bumps, self-resolves but treatable, hidradenitis suppurativa, inflammatory, affects sweat glands.
12-hour skin conditions, bottom line.
Irritants worsen everything. Lichen simplex chronicus, common for itch.
Right.
Lichen sclerosis planus are autoimmune, painful, increased cancer risk.
Let's discuss UTIs versus bladder pain syndrome, BPS, interstitial cystitis. Symptoms can overlap.
They can. UTI symptoms, frequency, urgency, burning, dysuria, cloudy bloody urine. But if vaginal discharge also changes, UTI is less likely. Dipstick tests are quick but iffy, false plus mic. Microscopy culture more accurate. But positive culture alone isn't always infection, asymptomatic bacteria.
Guidelines for suspected UTIs.
If typical symptoms, no vaginal discharge change, 2-3 year. Phone treatment might be okay if no kidney infection signs. See provider if no better. Recurrent, 4+ year, needs different management.
And BPS?
Chronic bladder pain pressure, urgency, frequency, pain with filling emptying, pain with sex, cause unknown. Inflammation, nerve pain theories. Important to check for pelvic floor, muscle spasm, and vulvodynia too. Cystoscopy screens for cancer, doesn't diagnose BPS, potassium test no longer recommended.
What about pelvic organ prolapse, POP? What is it?
Dropping of vagina cervix uterus towards or through the vaginal opening, main symptom. Feeling a bulge there. POP itself doesn't cause pelvic pain or pain with sex, graded with the POPQ system.
Management.
Pelvic floor muscle exercises can help. Fierce pessaries, removable support devices, are effective for most, 90%, even with higher grades sometimes. Surgery is an option, but recurrence possible. Mesh use, higher complication risk, usually for high failure risk without it, consider second opinion.
POP, bottom line.
Bulge is main symptom. Measured by POPQ, PFMs help. Pessaries often work well. Mesh surgery has risks.
Communicating with providers about these issues can be hard. Any advice?
Trust yourself, you know your body. Pelvic wiring is complex. Shared nerves for orgasm, pee, poop, can lead to mixed signals. Itch pain pathways overlap, so itch can feel like pain. Tolerance varies. Past experiences bias us. For example, assuming all itch is yeast.
Even doctors get it wrong sometimes.
Yes, she shares a story of misdiagnosing herself initially. Her advice: be precise about symptoms. When, how often, how long. Not just a self-diagnosis. Mention concerns before the exam. Focus on the bother factor. How much does it impact you?
Communication, bottom line.
Biology is complex, symptoms overlap, location confusing. Describe symptoms and bother factor accurately.
Pain with sex, dyspareunia, is it ever normal?
No, not normal. 10 common causes listed. Lack of lube, hormone changes, infections, skin conditions, vulvodynia, vaginismus, PFMS, fibroid sendo, ovarian cysts, STIs, psychological factors. Multiple can coexist. Muscle spasm, vaginismus, PFMS is super common, alone or triggered by others.
Does evaluation require a painful exam?
Almost never needed initially. Treat low estrogen first if present. If no cause found, see a pelvic floor physical therapist.
Pain with sex, bottom line.
Not normal. Tell a provider, get second opinion if needed. Many causes. Muscle spasm common. Painful exam usually not needed first.
What exactly is vaginitis?
Inflammation of the vagina. Causes discharge, odor, itch, pain. Common causes. BV, fishy, thin gray-white discharge, high pH plus whiff test. Yeast, cottage cheese discharge, itch, red, normal pH. Yeast on scope culture. Skin conditions, lichen planus. Irritation and discharge, red, ulcers, normal pH if no bleeding. Herpes, not typovaginitis cause but can cause redness discharge, resolves 10-14 days. Cervicitis, inflamed cervix, test for GC mycoplasma. Microbiome tests, not reliable for diagnosis now, 2 variable, positive yeast ad infection.
Vulvar itch, again, specific nerve stuff.
Complex signaling, different from pain. Acute itch relieved by pain scratching, chronic itch isn't. Light touch can feel like chronic itch. Avoid anti-itch products with benzocaine, risk of contact dermatitis.
Vaginal itch causes.
Hemorrhoids, treat OTC, prevent constipation. Pinworms, common with kids.
Yeah.
Perianal dermatitis, irritant reaction, aging skin plus stool exposure. Gentle cleansing, maybe steroid barrier ointments.
Vaginal odor cause.
BV, most common. Trichomoniasis, retained tampon objects, skin conditions, incontinence. DIV, disquamative inflammatory vaginitis, profuse discharge, high pH, maybe long-term non-estrogen contraception, non-oxynol-9 spermicide, harms good bacteria. Be seen while odor is present. Initial tests. pH, whiff test. High pH plus whiff suggests BV trich. Scope, cultures, exam, find others.
Bleeding after sex, postcoital bleeding, common.
Scary, often seems like more blood than it is. Affects 5%. First, rule out pregnancy, needs immediate attention. Non-pregnant causes. Cervical ectropion, common, normal. Cervical polyps, usually benign. Vaginal dryness, LULU, vaginal cervical infection. Chlamydia, mycoplasma, ureaplasma, treat patient partners, reevaluate. Cervical cancer, rare with screening. Trauma, GSM, thinning tissues.
Bleeding after sex, bottom line.
Happens 5%. Not menstrual bleeding. Ensure screening up to date. Infections, ectropion, common causes.
Let's do the medicine cabinet rehab. Topical med bases. Ointments versus creams versus gels.
Ointments, mostly oil, good barrier, slow drug absorption, fewer preservatives, feel greasy. Creams, 50-50 oil water, spread easy, faster drug delivery, need preservatives. Gels, water alcohol base, can be dry and irritating, especially on vulva vestibule.
And navigating Dr. Google, misinformation age.
Tough to discern quality info. Her prep work advice: do the National Library of Medicine tutorial, evaluating internet health information, bookmark it. Search reputable medical society sites, docgov.edu.org.com. Look for patient handout. Ignore celebrity advice, bias, genetics, attention-seeking. Check doctor funding on Dollars for Docs, ProPublica, for potential bias. Find share trusted medical pros online.
Online health info, bottom line.
Learn to evaluate info. Start with reputable societies. Wary of sites selling stuff or using non-medical language. Ignore celebs. Check for bias.
Finally, the Journal of Old Wives' Tales. Any good debunkings?
Oh, yeah. Drink 8 glasses water a day. Drink to thirst. Vaginal steaming, harmful. Vaginal tightening products, harmful. Jade eggs vaginal weightlifting, no science, culturally problematic. Hormonal contraception causing infertility, false. Garlic for yeast, no evidence, irritating.
And the book is heavily referenced.
Absolutely. Extensive scientific references listed at the end, plus personal acknowledgments.
So wrapping up this deep dive, what's the core message?
I think it's that your body is incredibly complex, and has been subject to so much misinformation historically, societally. Getting reliable science-based info is just crucial.
Yeah. Our goal is really to cut through myths, offer clarity from a source like Dr. Gunter's book. We hope, you, our listener, feel a bit more empowered now.
Definitely. Empowered to ask questions, seek out accurate info, advocate for yourself.
Exactly.
And maybe one last thought to leave you with.
Please.
Okay, so if history and society have shaped our view of the vulva and vagina so much, what other parts of our bodies, or even our health in general, might be similarly wrapped up in misinformation that we should probably question?
That's a really powerful question to end on, something to definitely think about.